Hello, and welcome to Direct Supply's Continuing Education webinar series. Direct Supply offers monthly webinars on a variety of topics throughout the year. The topic for today is defining a clinical pathway for improved cardiac care. My name is Robin Malik, and I will be facilitating today's meeting. Please note the information contained in this presentation is intended to provide general information, but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Today we are joined by Mark Besch, Vice President of Clinical Services at Aegis Therapies. Mark has extensive clinical and operational management experience in a variety of settings, including acute care. For the past 25 plus years, he specialized in senior health and wellness in home care, long-term care, and senior housing settings, and has broad experience with clinical program development, training, and implementation. He is a member of the American Physical Therapy Association and is active in industry advocacy and regulatory affairs. And now, please welcome Mark.
Thank you, Robin. And good day, everyone. Thank you for joining our webinar today. As Robin said, our topic really is defining clinical pathways and clinical standards around improvement of care for patients with cardiac diagnoses. For our organization, this sort of initiative was really prompted by, frankly, payment reform that we've seen over the last several years. Most tangibly, some of the bundled payment initiatives that we have been participating in for several years. So I'm going to spend a few minutes at the beginning of the webinar just sort of summarizing some from our perspective what's driving some of this evolution in clinical practice, where it's coming from, and our experiences. And then we'll talk specifically about how we've approached the structure, if you will, and design of care for cardiac disease patients. So going to bundled payment, what is bundled payment? And again, understanding that we may have a variety of individuals with different experiences, from zero to rather extensive experience with bundled payment. So I'll try to keep my comments at a fairly high level. But bundled payment is a kind of a new concept, been around for probably 3 or 4 years. CMS has started to use a term now called episodic payment models, or EPMs. And so you may see that term evolving more and more as well. But in terms of bundled payment, there's been a number of models that have been implemented over the last years. The early models from CMS, the bundled payment for care improvement models, which those models vary primarily based on the length of the episode and the services that are involved. In other words, the care that's involved from various settings. Some are limited to acute care only. Some of the models cover both acute as well as post-acute care. What's most important about the BPCI models is that they were voluntary. They are voluntary. So organizations literally applied to be accepted. They got to choose their diagnoses, choose the level of risk they wanted to assume in the program. So there were many choices to be made along the way. The more recent bundled programs from CMS, most notably the orthopedic bundles or comprehensive care for joint replacements, on the other hand, are not at all voluntary. And virtually all of those decisions were mandated by CMS for that 5-year bundled program. But most of the bundled programs are retrospective. That means that providers are paid up front, and there is a reconciliation or a true-up when the episode is over. So what's driving this is really this theme from CMS that you may hear referred to as the triple aim: better care, smarter spending, healthier people. A couple of years ago now, then Secretary Burwell, in an address, described that triple aim, I think, extremely well. And you can see the quote here on the screen. And she just talks about different constituents: patient, provider, businesses, health plan, taxpayers, She said it's in our common interest to build a healthcare delivery system that's better, smarter, and healthier. So one that delivers better care, spends healthcare dollars more wisely, and makes communities healthier. So that's really, if you think of very broadly what's driving payment reform from a CMS perspective, those are the two primary objectives. She went on in that address to describe some payment goals, which we'll look at in just a minute. So from a thematic perspective, it's that triple aim. From a reality perspective, it's really the IMPACT Act, passed back in 2014, but really now is being more and more, the different components of the IMPACT Act being more and more implemented, which is also contributing to payment reform. Quality, the focus on quality, moving from paying for volume to paying for value is really all about what this payment reform is driven by. And the IMPACT Act has a lot to do with collecting data on quality, establishing quality measures, and then collecting a standard set of data across the post-acute care settings. So why all this attention on post-acute care? Really, it's about cost. It's the escalating costs, and it's about the lack of standardization and interoperability, or really comparative results across the post-acute settings. So the goal is they want to establish payment rates based on the patient, not the setting. And so in order to do that, obviously you have to collect standardized information across the post-acute settings. So what do they hope to accomplish with these alternative payment models or episodic payment models? Well, they really want to raise the level of the percentage of payment that is used in these models. And you can see the one goal that Secretary Burwell talked about back in January 2015 was to move the percentage of Medicare provider payments in alternative payment models, move from 30%, which is where it was in January of 15, to at least, or move to 30% by the end of 2016. And so now we are there, right? And they made that goal. They actually hit 30% in the first half of 2016. And then you'll see they want that goal to be 50% of provider payments to be made in alternative payment models by 2018. And the introduction of more bundled payments certainly facilitates them achieving that goal. And you see the second goal that she talked about was linking payments to quality and value, and not just on volume. And those goals are even more aggressive, up to 90% by the end of 2018. So the goals of bundled payments are to promote quality and financial accountability, obviously reducing Medicare expenditures while preserving or enhancing the quality of care. So in these different bundled payments, there are attempts at quality measures that are used to help determine what a provider might be able to earn in terms of additional incentives or payment for meeting some of the goals for reduced expenditures. So what's really different if you're involved in bundled payments? Well, target rates gets established for the specific diagnostic categories. In the example of BPCI, as I said, providers could choose those diagnostic groups, those DRGs. In the example of the orthopedic bundles, CJR, the DRGs were specified for you. And so there wasn't that choice. But at any rate, a single entity then holds the responsibility for the entire period of the bundle as it's defined. Some bundles are 30 days. More commonly, bundles are 90-day episodes. And so that single provider is ultimately responsible for all of the costs that are incurred for that patient's care during the during that episode bundle. But during the bundle, as I said earlier, all providers are paid under the prevailing payment models. But all those costs get aggregated And that's what becomes then the episode cost. And the actual episode cost then gets compared to the target rate. And providers that are able to have their costs fall below the target rate have an opportunity to share in some of that savings. They can earn some additional payment from CMS, assuming they meet the quality measures. Providers whose actual episode cost exceeds their target rate face the liability of having to pay the Medicare program a portion of those additional costs, so those costs in excess of the target. And so really, these are designed to improve value. They have clear metrics that are focused on outcomes, and those providers have to meet those metrics in order to optimize or maximize their reimbursement opportunities. So providers are incented. They have to think and act differently in the way that care is planned and delivered. If there's one theme that you take away from understanding bundled payment, it's the need to think and act differently in terms of planning and delivering care. We'll talk about that in just a little more detail. So what do we mean by care delivery different? Well, because the owners are responsible for all of the care, that means regardless of the provider, regardless of the setting. So one of the big differences is an emphasis on much more coordination and collaboration across the settings during the episode. Because the keys to success, as you can see on the screen here, number one is obviously controlling costs. And there's two primary ways to do that: managing length of stay in any given setting, as well as reduce or avoid return to hospital, rehospitalization. That, along with maintaining quality and then demonstrating value to the beneficiary, because the beneficiary has a say in their experience. So virtually every payer has been talking about this. So what does it take to think differently? It means you have to be patient-centered, it means you have to be collaborative, and you have to demonstrate value. So more tangibly, what does it mean? If the goal is improved coordination and transitions of care and reducing expenditures, what does that mean a little more tangibly to a provider? It means that patients are likely to transition through care settings quicker and maybe even avoid some care settings that add cost. And so it's critical that any care setting, regardless of the post-acute setting that you're participating in, realizing that your setting singularly will not likely need to meet all of the patient's need. We talk a lot about patients' rehab needs, but really it's understanding the portion of a patient's need that is most critical in that setting in order to facilitate a patient's safe and effective transition to the next setting. As we work with our therapists and our customers on understanding how delivering care has to change, that's one of the principal factors that we emphasize, is being able to identify what are the barriers for this patient to transition to the next level of care, and what's our role in helping to eliminate those barriers. Next couple slides just have some graphics on them that we use when we're working with therapists, and it may be helpful to sort of use them as an example of how we underscore this concept of care redesign and thinking about transitioning patients through care settings. What you see on the screen here is just a common visual that we use in our organization, because we measure functional change with our patients in many, many different categories. This is just one example of a patient who has a number of functional areas that are being addressed in physical therapy. The darker shaded area represents their status or their functional rating, if you will, when they were admitted to therapy. And this particular one is done on a 3-point scale, from 0 being dependent and 3 being fully dependent. So you can see most of those, that center area there, clustering somewhere between 0 and 1.5. And then the outer lighter shaded area represents their functional ability on the same scale, but at a later point in time, perhaps at discharge or perhaps at an interim period. So what we do in terms of helping folks understand the transition of care principles is we overlay that. So now those graphs are really in the background of the slide, and we overlay that potential care settings that our therapists are commonly involved with: skilled nursing facilities, home health agencies, and outpatient clinics. And what this slide begins to represent, you see that this particular patient, if you can sort of look through those circles to where the higher levels of functional achievement occurred, you see that the patient doesn't necessarily max out their functional ability in any single setting. They transition and they continue to improve across settings. And so that's really what we talk about with therapists is help patients transition to those settings, realizing that their ultimate functional outcome likely will not be achieved in the very first setting that they receive services in. So hopefully those images may have helped a little bit. So what does it mean? It really, again, we talked about it being patient-centered, collaborative, and delivering value. And this quote you see on the screen here is actually from the final rule from CJR, where CMS, they talked about believing that the CJR, that's the orthopedic bundles, will incentivize hospitals and post-acute providers to do what? Focus on the patient experience throughout the episode of care, so patient-centered, by collaborating and coordinating services so that they can demonstrate value and efficiency. So really quick, just in terms of bundled payments, how does it work? And I've just got a slide or two on this, and we've described that in some depth already. So the orthopedic bundles, or the CJR bundles, started in April. So we're 8 months plus now into that 5-year program. As I said, participation was mandatory, and it was based on geography, defined as the Metropolitan Statistical Areas, or MSAs. So they identified 67 MSAs that if you're a hospital in that MSA, you are mandated to participate unless you're already in another CMS bundled project. And so that was about 800 plus hospitals in 33 states. So again, the aim was more efficient care for the beneficiaries and have post-acute providers working together. So Avalere did an analysis just before the launch date of these bundles, and they said the launch of this project marks a shift in how CMS is approaching payments, and suggested that providers everywhere, whether you're in one of those early mandated bundled areas or not, that they should take note and study bundled payments because it would be likely to expand. They also said that hospitals at that point typically didn't know where their patients went. They may know where they went, but they didn't really follow those patients. And yet, a hospital's success under CJR was going to hinge heavily on being able to track patients and partner with high-performing post-acute providers. So that's why it's so important for post-acute providers to understand bundled payments, because hospitals are going to be looking for high-performing post-acute partners. So what will those hospitals expect? They're going to establish certain metrics that they will expect of their post-acute providers. This is a list of some common ones. Each hospital can create their own. And so as bundled payment expands, which we know it will and has, it'll become even more important. Interestingly, in that Avalere report in March of last year, they said that they expected that during the final year of the Obama administration, that there would be more mandatory bundles, and they looked for to accelerate that transition to value-based care. Remember, that was published in March, and we know that the first bundles This is an analysis that was taken from a Dobson and DeBonzo report, and I show it just because it demonstrates why CMS chose the lower extremity joint replacements as their first bundled project, because it is the single largest group of patients and highest expenditure for CMS. So they targeted that as an opportunity to lower expenditures. So now we see that prediction that bundles would expand, and in fact, in August, new bundles were proposed, and in December, the final rule was issued around these 3 more bundled payment initiatives: 2 for cardiac patients, 1 an expansion, essentially, of bundled payments for orthopedic patients. And then there's also a 4th initiative that is really hospital-centered, and that's an incentive payment model for cardiac rehabilitation. So what we saw indeed is an expansion of bundled payments that will start in July. These cardiac bundles, let me start with the hip fracture bundles. Those, the geography for those will absolutely match the CJR bundles, so the same MSAs were selected. The 2 cardiac bundles, myocardial infarction and coronary bypass surgery, have a different set of MSAs. There were a total of 98 MSAs selected, and interestingly, 17 of those 98 are MSAs that are also involved in the orthopedic bundles. So those are the lucky 17, so to speak, because they will literally be participating in all 4 of these bundles, assuming, again, the hospitals are financially responsible, and for patients that they admit and then discharge, they'll be evaluated based on the 90-day episode and all of the costs incurred during that 90-day episode. So how did they go about choosing those? Well, again, same chart that we saw earlier, but look where these new patients fit within that chart. Interestingly, not the 2nd and 3rd and 4th highest expenditure groups, but certainly within this top dozen or so. And for those of you that might be looking at, well, if there's more bundles that might be forthcoming, what might CMS be looking at? I would suggest probably the top part of that grid, heart failure, COPD, pneumonia. But again, that's conjecture on my part. Don't take that to the bank. But it's interesting how these line up with the expenditures. So what does it mean? What are keys around this? And then we'll get into what we've done to standardize cardiac care in preparation for these cardiac bundles. First of all, because the hospitals are the financially responsible, it's critical that providers understand what the hospital approach is. So you have to meet with the hospitals. You have to talk to them. What are they thinking? Will they take a wait and see approach because the risk phase for these bundles was phased in? Although the phase in for the orthopedic bundles, CJR, is now over. So as of January 1st, every hospital is fully at risk and may face repayments. So they may be more interested now than they were last April. There is a phase in for the cardiac bundles as well. But point being, you have to understand the hospital's position. You have to understand the market dynamics. How many of these types of patients or procedures are performed in your hospitals? What is your risk or your opportunity to compete for those types of patients? You have to know your own metrics, because what's important to the hospital? We know that length of stay in post-acute settings is important. We know that admission rates from post-acute settings is important. We know that 5-star ratings are important because it determines some of the eligibility for reimbursement. And so clearly, episodic cost, whether you're in a SNF or whichever post-acute setting you represent, is important to understand. So once you understand your market dynamics, you want to understand your position in the market, again, knowing your own metrics and realizing that readmissions is absolutely a major driver of episodic costs. We've seen it with the CJR bundles. A hospital readmission can add 25 to almost 50% to the cost of one of those bundles. So opportunities, training efforts with your entire facility team, helping them understand bundled payment and what the success is going to be like. Helping hospitals with patient placements. That means being attractive to the hospital as one of those high-performing post-acute providers, and developing and offering clinical pathways. I mention it here because our experience in CJR is that the discussion around clinical pathways and standardizing approaches to care is the single most important dynamic that we've spoken about to hospitals, that resonates with them most clearly and most loudly and gets their interest most quickly. Because the ability for a hospital to have a confidence and an understanding from their post-acute providers as to exactly how care is approached and standardized means a great deal to them as they try to understand their cost. And so we're going to spend really the rest of my time today talking about exactly that, pathways and standards of care for purposes today for patients with cardiac diagnoses. So what you see on the screen here, and I realize it's a little difficult to read, but the point here is that historically most clinical pathways are written based on a setting, certainly a diagnosis. So you can see this is an example of a coronary artery bypass patient pathway. It's for post-acute phase, and it's written for an anticipated length of stay of 21 days. So again, they're very chronology-based for a predicted period of time. And that might vary depending upon the provider and the setting and so forth. But this is sort of a historical, traditional clinical pathway. Our functional pathways that we use today are very different. They are not setting specific, and they are not specifically chronology based. Rather, they are based on functional milestones. And so depending on a particular patient's functional milestone, not every patient enters this pathway, for example, at the column on the far left, whereas a pathway that's purely chronology driven typically does. A patient can enter this pathway at any point in time and at any functional milestone, and the pathway simply helps guide and standardize the care that's delivered from that point forward. So they're very setting agnostic and much more broad. They do have some level, and I realize this slide is impossible to read, but the only point of even showing it is that we do have, this is a page 2, if you will, of a clinical pathway that is specific to therapy. So there's a physical therapy section, an occupational therapy section as an example, so that we do provide that level of specificity. And this is where we get into some of the standards of care that I'm going to describe and that you'll be able to see much more easily on some of the slides here that I'm going to start with. So there are several common, what we think are critical components that, again, our experiences are very attractive, if you will, and get the attention of the conveners, in the case of the bundles, the hospitals, as it relates to care for their patients. One we talked about, clinical pathways. Secondly, I would say is establishing standards. Again, consistency in the way that care is delivered to patients of particular diagnoses is of high interest to those who hold the financial accountability for the bundles. And so I'm not going to go through these slides in great detail and go through each and every one of the bullets on these slides, These are examples of standards of care that we've established for the rehab component of a cardiac care program. And so again, don't mean to represent this as the be-all and end-all. These are examples from our program, but they are founded, they're very well founded in evidence and in the literature. The most important thing to take away is not all those bullets, is that you do want to establish standards. And so we'll talk about some of those just a little bit. So as an example from our program, exercise standards become very important. What are the guidelines that our therapists use when they determine, as you can see on this slide, intensity, duration, and frequency of exercise that they're going to recommend and prescribe for these patients? So have standards that can be applied. What about circuit training? What about upper extremity weighted resistance? For, again, this is specific to a bypass surgery patient. So you want to have standards around the degree to which you're doing upper extremity resistive exercises. And what are those standards? You can see ours, but again, it doesn't mean that yours need to be the same as ours. The point is that you want to establish those. Same thing here on this slide. For intensity, for duration, for frequency, establishing standards is important. The next thing, so in addition to establishing pathways and establishing standards of care, it's critical and strengthens your program to make sure that you're using evidence-based, standardized tests and measures. Those that are well-founded in the literature and for many of them have strong clinometric properties, which means there are benchmarks. There are you can determine the minimal clinically important difference. I'll explain that term in just a moment. An example of a standardized test and measure that we use in our program is a test that's called the 6-minute walk test. Doesn't mean you have to choose that test. It just means we have a standard. It's a standardized test that we use, that our therapists administer to all of the cardiac patients that are enrolled in this program. So again, consistency of the way you deliver care speaks very strong. So again, these are just snapshots from our training. So how does one administer this standardized test that's called the 6-minute walk test? And it's exactly what it sounds like. It's the distance that an individual can walk in a 6-minute period of time. And then there are norms associated with this test. These are not our norms. These are published norms in the literature as to, for a given age, for this population, what can you expect? And the clinometric properties that become very important, a property called the minimal clinically important difference. And a good standardized test or measure will have these clinometric properties, this one in particular, and it will be diagnostic specific as much as possible. So you can see here, the MCID is essentially the minimal change in the score on that test. So in this case, the distance that the patient is able to walk. That really is determined to impact the patient's function. Why is that important? Because you might use the 6-minute walk test, and you might report from to compare 2 points in time, the patient has been able to increase their walking by 20 meters. Well, if the minimal clinically important difference for this test, for that patient, as an example, with heart failure or COPD, is 40 or 50 meters, then reporting a 20-meter change may be an indication of change, but according to the clinometric properties, it's not a clinically important difference. So you have to achieve even greater change to really make a clinically important difference. So I don't want to belabor that point, but again, when we talk about using evidence-based standardized tests and measures, that's the degree that we feel like it's important to go to make sure that we're choosing the right measures to use. Engaging the patient would be another critical principle that we think is important in success of these types of programs. We focus on a concept called health literacy. It's not our concept. It's available in the literature. Again, we want to use evidence-based information, but it's focusing on the patient's ability to understand healthcare information. You can do a lot of teaching and training, but if you haven't assessed the patient's ability to receive that information, you may be limiting your ultimate effectiveness. And so, interestingly, the AMA reports that health literacy is actually a stronger predictor of a person's health than age, for example. Now, you see some other ones there that are less dramatic, in my opinion, but really health literacy is a better predictor of a person's health than age. And so that's powerful. You can see some additional reasons why that support focusing on health literacy. This slide just sort of emphasizes that the degree to which people really have adequate health literacy is lacking. Fully a third of English-speaking don't have adequate health literacy, and in excess of half of the Spanish-speaking respondents in this particular study. So again, the conclusion is low health literacy impacts the patient's ability to understand and limit their ability to care for their own problems. Now, in an environment that puts more responsibility to transition patients to lower levels of care, to try to transition patients to taking more responsibility for their own care and recognizing signs and symptoms and reporting them appropriately, health literacy and understanding that information becomes even more important. So people with better health literacy tend to help manage their disease and experience better results in terms of managing their condition, preventing admissions, and so forth. So we use a tool, again, not our tool, but that's available, that you can assess an individual's health literacy. It's called the Health Literacy Tool, and it uses some common nutrition labels that the person is asked to read and interpret. So again, my purpose today is not to provide training on how you deliver this health literacy tool, but rather to say that when you choose to focus on something like health literacy, you want to go to the literature. Does it support that makes sense? And then what tools are available that have proven evidence behind them that they can be helpful in you determining the information that you want to know so that you can provide the best approach to training to improve literacy and thus help your success. Another way to engage the patients we find is through journaling. So again, I said earlier that part of transitioning a patient to a lower level of care, you want to have them more involved and more responsible for managing their own care and condition. And so we find a great way to do that is to have them journal, have them write things down in their own language that can be reviewed with them. And it provides them great motivation as they see change. And so the degree to which we do that, we have a patient transition notebook that we have the patient write down certain components. We prescribe what those components are depending upon the diagnostic group that the patient is in, and then that can be easily reviewed with any caregiver. So we want the patients to have one notebook they use, and regardless of the setting that's going to be following them or recheck appointments that are made. And so So really, to summarize, and then the last several slides, I know some of you will be interested in getting the slides, so the last several slides are really just the references for those resources that we've used. So again, when you talk about structuring care, just by way of quick review, those critical components that we feel and have incorporated into our program: clinical pathways, establishing standards of care, using evidence-based, standardized tests and measures, engaging the patient. We think health literacy assessment is an important part of that, but engaging the patient. So those would be the 4 primary success factors, if you will, from our perspective. So again, pathways, standards of care, evidence-based standardized measures, and engaging the patients. So with that, I will pause. Robin, if there are questions before we go on to our next presenter.
All right, sounds great. One question: how do you think our new president will impact bundled payments?
That's a great question, and I probably should have put an asterisk on some of the comments that I made, because that's a real unknown right now. I talked to some quote-unquote Washington insiders that we interact with from advocacy efforts, and everyone agrees it's kind of an unknown. We're going to have a new Secretary of Health and Human Services. Congressman Price has been somewhat critical of some of these alternative models that the Center for Medicare and Medicaid Innovation, CMMI, has proposed. He has, in some circles, encouraged that those efforts be slowed down. And so I'm not sure anybody knows. I think they are at risk to some degree. So we do have to overlay all of those comments with an understanding that the political arena could very well alter some of those approaches. I'm not smart enough to be able to predict exactly what that'll be. I'm going to be in D.C. in a couple weeks, listening to some more folks with some thoughts. I think we're certainly watching the Senate hearings closely in terms of the approval votes on the cabinet nominees. I think that will have an impact potentially. So but it's a great question. I appreciate the listener raising that.
All right, that's all the questions I see so far. And now for anyone interested in learning about the innovative product solutions in monitoring, rehab, and education that Direct Supply offers, I'd like to introduce Brad Johansen, our Senior Product Consultant. Brad has spent the last 12 years at Direct Supply working with care providers to identify and implement effective clinical product solutions. In his current role, Brad focuses on validating new innovations in areas such as cardiac care, short-term rehabilitation, and device connectivity to EMRs. Please welcome Brad.
Thank you, Robin, and thank you, Mark, for a great presentation. We are just transitioning our slides here, and we'll go ahead and get started with a review of some of the newer innovations that Direct Supply has been validating in the long-term care space for the last couple of years, in addition to the traditional catalog and online offering that you all may be used to. We do have a number of clinical events throughout the year, both in Milwaukee and throughout the country, that bring clinicians and therapists and long-term care leaders together to evaluate new products, new services, new innovations that are very much tied to many of the capabilities and outcomes that Mark talked about today. So I want to spend a little bit of time highlighting some of the things that we have been able to bring to market, things that we've been able to test, some case studies that we've been able to write that have really made a difference in terms of assessing, monitoring, providing rehabilitation and educational services to cardiac patients. And the solutions I'll talk about today are very much in line with some of the themes that Mark talked about. So much like care redesign itself, a lot of the solutions we evaluate don't just need to have a good price point or a good freight price or bells and whistles that appeal to you on a catalog page. They need to be patient-centered, meaning they need to have features that allow you to make faster decisions, to become more efficient in terms of your nursing operations, to allow older, more frail residents to get into certain rehab devices, to provide additional reporting and information that allow you and your referral sources to collaborate more effectively. At the end of the day, they need to demonstrate meaningful value, and I'm excited to talk about a few of those solutions today in the areas of patient monitoring, rehab, and education. One of the first solutions I want to talk about is this new web-based, software-based ECG device from a company called Spaulding Medical. They're actually based out of Wisconsin. And for those of you who have seen a traditional ECG in a building before, they are usually a larger tabletop device that attaches to a resident with 10 electrode wires, prints off a piece of paper, and from there you typically have to do something with that paper, get it to a physician or a cardiologist to overread, fax it to an outside location. And in terms of the skilled nursing environment, we find that most providers today, when an ECG is ordered or when there is an emergency event, oftentimes have to do one of two things. They either automatically send that resident out, or they have to have an outside company come in to take that reading. So with this new device, the little round puck shaped product is actually the ECG itself. So the first innovation is that this product is now significantly smaller. So it's not this boxier device that you have to store in a closet or move around throughout the building or take up additional footprint space in the resident's room. It's now extremely mobile. It attaches to the resident with the same 10 electrode wires that you would use on a traditional ECG. But from there, the workflow is significantly different. We build a customized website for your building or for your organization. We allow your nursing team and your administrators to log into your website, load your patient orders, and now you're running an application off of a tablet or an iPhone or a laptop, and you place the device on the resident, hit one button, bring up your application on your tablet, and from there you see within seconds a full 12-lead ECG streaming across the screen. You can save that reading electronically, you can manually save it into your electronic medical record, and you can have it automatically emailed to physicians or any decision makers that need to see that reading quickly. The whole purpose is to provide the resident with an experience that's a little more comforting, a little bit less intimidating, very quickly get those readings in an electronic format, and then have them sent to the proper decision makers within minutes, compared to waiting for that resident to be sent out or to have an outside company come in. We put this device in 8 centers in Michigan with a group called Sienna Healthcare, and most of those centers were either sending folks out or having a mobile ECG company come in. And as you can see in the chart here, the results were pretty impressive. Prior to implementing the Spaulding device, it was taking 24 to 48 hours using their outside mobile company to determine the results of that 12-lead ECG. So as you can imagine, with that time frame, anytime we thought there was a heart failure event occurring, that was going to be a readmission. They were able to reduce that time down to 5 to 20 minutes per event. And because of that, they not only saw their usage of ECGs increase for those emergency events, but they also found a variety of ways to use the device for other things. Mark talked about getting a baseline, and not just for vitals, but getting an ECG when a resident is admitted or when there's a medication change. Oftentimes, if a resident is going out for a surgical procedure, a physician will want an ECG taken. There's a variety of things that you can use an ECG for that maybe you didn't think of before or couldn't do because you either didn't have one in-house or because an outside company would take a little too long to get there. So the key conclusion from this study was that one of the buildings within the first 90 days was able to eliminate 10 unnecessary readmissions to the hospital. So with the price point of this device being in the $2,000 range, we have found it to be not only a disruptive price point, but a really innovative feature set that allows skilled nursing centers to quickly take readings, get it to the right decision makers, and hopefully either determine if an admission is necessary or, of course, eliminate those unnecessary trips back. Another really innovative solution that we've been working on for the last several years is the Welch Allyn Connex Spot Monitor, or CSM. So in the spirit of workflow efficiency, of reducing errors, of improving decision-making time, this is a combination vital signs monitor that will take your temperature, blood pressure, and pulse oximetry, and has the capability to wirelessly send readings automatically to the patient's chart within certain EMRs, point-click care and matrix care being the two big ones they can communicate with today. So as you can imagine, if the average workflow involves a CNA taking manual readings, writing them down, finishing her rounds, entering that data in either to a paper chart or typing it into your electronic medical record, that takes time. That can potentially leave room for human error. And you have your nurses who would like to make decisions off of that information, would like to complete their med pass. And if you can now bring up the patient's name on the device, take a set of vitals, hit the save and send button, and have your nurses' charts and tablets, laptops up to date with real information within seconds, that has shown to dramatically reduce errors, improve decision-making time, and just improve overall workflow efficiency within the clinical team. We have implemented and piloted this throughout a variety of organizations, one being the Marquise companies on the West Coast, and they have seen some pretty dramatic results in terms of their workflow efficiency. This slide highlights some of the time savings that was measured when using the connected device compared to handheld monitoring solutions. So before we even got to the efficiency associated with connectivity, they realized that just by taking vitals with an automatic hospital-grade combination device such as the CSM compared to a manual BP cuff and handheld devices, they were able to save on average 76 seconds each time a CNA took a set of vitals. And that is a really important number, not just because of the time saving itself, but because within our pilot building, staff was having a hard time getting MedPass done before breakfast. So what they found was that they would be halfway done taking their spot checks. They would have to start moving residents to the kitchen for breakfast. That was creating a pretty big time lag in their ability to get their MedPass done. So that 76-second savings allowed them to get their vitals taken and MedPass completed before breakfast, which really greatly enabled them to allocate caregiver time to other things and obviously make faster decisions. So when they took that time savings, that 76 seconds, and they extrapolated it across their organization, I think they have about 30 buildings or so, they figured out that as an organization, they're saving 31 CNA hours per day and just under 20 registered nurse hours per day. If they multiplied that human resource cost out across an entire year, that was approximately $400,000 in annual savings just in terms of nurse time. So that's not money in the bank, but that's caregiver time, almost $500,000 worth of caregiver time they were freeing up now by saving that 76 seconds. So again, it's resident-centered, it's allowing collaborative and more efficient communication, and it's driving better results. So we're a big fan of this solution. From a rehab perspective, I think we could do a webinar on all the various solutions we have in this space, but in the spirit of common themes, we really want to focus on making sure that you have the devices that have advanced configurations that can allow you to adapt devices to a wide variety of residents with varying capabilities. So if you're going to spend those dollars and that relatively limited physical space on products like treadmills and fitness equipment, you want to make sure that you're getting as many features as you possibly can out of those devices. Adjustable handrails, devices that measure stride length, being able to do incline and decline, and a variety of things that you can't do on your traditional fitness or exercise treadmill, I think is really important for the cardiac care population. Easy access is a huge factor that is oftentimes overlooked. If the average long-term care building has 15 to 25% of the residents in wheelchairs, but none of their devices in the rehab space have 360 swivel seats or removable seats for wheelchair access, that could be potentially a large amount of your population that can't engage in exercise. Things like low incremental adjustments. If the average person over 80 can't lift 10 pounds, but your weight stacks on your strength equipment start at 5 to 10 pounds each, that again limits the amount of individuals who can participate. Having devices that start at a tenth of a pound and go up from there really change the game in terms of who can participate in exercise and how quickly you can engage with their programs. And finally, there are a variety of products that can integrate together and that run off of software tools so that as you create programs for individuals, they can track your progress and create reports that you can then market to your broader teams, to your referral sources, to family members, and again, demonstrating that value, showing the results that your new capabilities are driving is a really important thing that we can help you with from a product perspective. And finally, there's only so much you can do for a resident while they are within your care, and even less once they transition to home or to another setting. These transitional care kits are boxes and bags that are specific to chronic diseases. CHF, hip and knee replacement, diabetes are very popular ones that have a variety of products, supplies, and educational materials that you can give away or perhaps sell as a revenue stream to discharged or transferring residents to aid them in maintaining their care plan. Mark talked a lot about health literacy and their ability to understand what they need to do to participate in their care plan, and these do just that. They have a lot of clinical evidence behind them, have really driven some positive results in the buildings who have been using them, and overall just help residents and their families care for themselves after they've left your care. So again, there's a variety of these available. We have a variety of information available on our website. We've launched a new cardiac program with a wonderful white paper and a mini catalog of a variety of solutions that I've highlighted here today, as well as many things that I haven't. So Robin will be sending out some links afterwards with some additional access to information. At this point, I will take any questions that we have.
All right. The one question that came for Brad is, does the web ECG interface to PCC?
At this point, it does not automatically integrate to point-click care. It does provide you with an automatic PDF, which you could manually enter into it or save into it. We are in discussions with a variety of EMR companies about best ways to send that information over. PCC specifically has some changes coming through in the way their software is set up. And so we are definitely at the forefront of trying to make sure that not only do our solutions integrate, but they integrate properly. And I think last time I checked, PCC might not even have a space for ECGs to go into. I think it would actually be saved into a miscellaneous file. So not today. It's a little bit more of a manual process, but we are working on it and hope to have more integrated solutions in this space within the next 6 to 12 months.
All right. Thanks, Brad. Mark, we had one more question come in for you. Is the 70 code required on the claim, even though it's not a 3-day qualifying stay?
So I assume the question is referring to the waiver of the 3-day hospital stay that might be available under the bundled payment program, particularly CJR. And if it's not, if the patient did not have a 3-day qualifying stay, but the facility does qualify as a waivered facility, then yes, that code is required.
All right, great. Well, thank you both. For more information about upcoming webinars or to view past webinar videos, please visit www.directsupply.com/webinars. And once again, thank you for attending today.